Hello, I'm Lauren Richardson. Just want to take the opportunity to thank JBI Network for the opportunity to contribute to such an important digital resource. Really encourage listeners to please consult the JBI website for access to this paper. The title of the paper is Protecting Nurses Against COVID-19 in Emergency Departments at a Teaching Hospital in Tabriz, Iran, a best practice implementation project. So by way of background, the prevalence of COVID-19, I'm sure much of you are aware, is higher among frontline healthcare workers, including nurses, due to their occupational exposure. So the aim of the project was to improve the protection of nurses from COVID-19 in the emergency department at the teaching hospital. The implementation project used the JBI evidence implementation framework, grounded in the audit and feedback process, along with a structured approach to the identification and management of barriers to compliance with recommended clinical practices. So there's 7 stages, including identification of practice area for change, engagement of change agents, assessment of context and readiness to change, so a situational analysis, review of practice, so baseline audit against evidence-based audit criteria, implementation of changes to practices, reassessment of practice using a follow-up audit, and consideration of the sustainability of practice changes. So the project used the JBI practical application of clinical evidence system, or JBI PACES, getting research into practice, or GRIP, audit, and feedback tool. And this involves 3 phases of activity. 1, establishing a team for the project and undertaking a baseline audit based on the criteria informed by the evidence, reflecting on the results of the baseline audit and designing and implementing strategies to address non-compliance found in the baseline audit, informed by the GRIP framework. And finally, conducting a follow-up audit to assess the outcomes of the interventions implemented to improve practice and to identify future practice issues to be addressed in subsequent audits. So just to summarise the results, the baseline audit results showed that the compliances for 4 out of the 10 criteria were under 75%, and this indicated poor and moderate compliance with current evidence. After implementing educational programs and meetings, major improvement was observed in 3 of these criteria, 4, 7 and 9. So criteria 4, just for listeners, was improved from low to excellent, so from 41% to 81%, so it's quite a big jump. And that is that all patients presenting to a healthcare facility suspected of COVID-19 are triaged. Criteria 7 was promoted from low to moderate, so from 30% to 62%, so that's quite good. Social distancing is in place at the triage station. And criteria 9 was improved from moderate to excellent, from 70 to 84%. Standardised IPC precautions are taken by all healthcare workers. So just criteria 9 is the 4th one, and it only improved slightly from 22 to 27%. And that is that a hand washing station is provided at the triage station for use by healthcare workers, patients and visitors. So the authors do address this in their discussion, and spoilers, the barrier is a lack of financial resources, which isn't surprising. Anyway, we'll discuss it later. But the authors conclude the results of the audit process increased COVID-19 protection measures for nurses in the emergency department, and thus educational programs and tools such as face-to-face training, educational pamphlets, workshops and meetings can facilitate the implementation of evidence into practice. So in the discussion, the authors highlighted that there was some good knowledge about the prevention and control of COVID-19 among healthcare workers in Ethiopia, even though practice was poor. And this was due to having access to vast information resources, including media platforms, social media. And on the other hand, lack of time, shortage of PPE and heavy workload led to poor practice. So for instance, the hand washing station provisions for nurses and patients were 22% compliant with the best practice, and this remained much the same after the follow-up audit at 27%. And this was due to a lack of financial resources to provide a station in the triage that I mentioned briefly before. And the authors refer to a review which also found that a shortage of financial resources was the main challenge in providing water, sanitation and hygiene services in low-income countries. So I guess the take-home here is that governance and financial resources are very common barriers for many implementation projects in healthcare, and that these are really important factors to be across when you're considering effective interventions for improvement. It's also worth noting that social distancing in the triage station of acute settings was not compliant with the best practice. So the compliance rate was 22%. And this was improved after the intervention. However, the compliance rate in the follow-up audit jumped to 62%. So the authors did allude to this being attributable to the social distancing policy implemented in Iran at the time. And the policy was endorsed by social media and supported through a variety of campaigns. And this appears to have impacted on improved practices. So highlighting, it's also important to understand the policy context and how this interplays with implementation strategies. So overall, the authors have demonstrated from their perspective that a clinical audit is a useful tool to improve performance with the aim of resolving identified issues. In this case, educational programs and meetings were facilitators of successful implementation, and suggested that leaders should consider these when looking to address the protection of nurses in EDs against COVID-19 in similar settings. But I just want to offer some of my own insights. I think that more than this, they've demonstrated how implementation science plays a vital role in the response to COVID-19, in that very simple, cost-effective strategies can be implemented with measurable impacts. And these are really important tools for healthcare leaders to have in their toolbox to enable a flexible and adaptive response to something that's so complex and forever changing, like the COVID-19 pandemic. And it's true that infectious disease outbreaks are inevitable, but it's important to remember that these impacts can be minimised by good, comprehensive disaster management. The COVID-19 pandemic is a disaster in its own right, but there are other disasters that tend to evolve from here, depending on how we respond. For example, social, policy, and economic disasters. So it all depends on the way we respond, and it's this complex interaction of human behaviours as a response to the disaster that determines the impact it has. And in terms of the protection of frontline healthcare workers, they play a vital role in containing the spread of the virus, whilst being at the greatest risk of exposure, given they're continuously in close proximity with suspected and confirmed cases. In fact, nurses make up the majority of frontline healthcare workers, and so as a cohort, nurses are at an increased risk. And for that reason, this particular study is a really important contribution to the protection of nurses working during not just the COVID-19 pandemic, but for future pandemics in terms of preparedness, response and recovery. So many countries saw the daily case numbers among healthcare workers as a proportion of the total daily number rise considerably. So prioritising infection control in this cohort is critical to enabling the continued delivery of essential services, given the impact on healthcare workers' ability to withstand the effects of responding to a pandemic and, importantly, to build back better. And with this in mind, and in addition to protection from exposure to the virus during the pandemic, the authors also highlight, quite rightly, it's just so critical to manage health and resilience of healthcare workers to ensure the continued delivery of health services over time. Thus, adequate pandemic preparedness plans are really key for managing the risks associated with airborne transmission by infected healthcare workers of COVID-19. An adequate response should be based on an all-hazards approach, which allows for the response to a wide-ranging scenarios, but it's flexible and adaptable depending on the way and in what context the event unfolds. So it needs to factor in social, economic and health implications in both the immediate and the longer term. Importantly, when considering the robustness of healthcare workers' ability to respond to the pandemic, the close monitoring assessment of additional safety measures is required. So, for example, psychological distress, fatigue, occupational burnout, stigma, workload, etc. And the authors allude to this as well in their background. They talk about that even though that there was considerable knowledge amongst healthcare workers about what to do, the workload really impacted on their performance. So inadequate protection of healthcare workers has seen hospitals struggle with workforce and infrastructure problems due to the inevitable staff absenteeism, which then undermines hospital pandemic responses. And this is because, aside from an OHS perspective, protecting healthcare workers is critical to ensure a resilient health system. And this isn't just low income countries. We've seen this in, for example, right now in Melbourne, Australia, large healthcare worker outbreaks have led to the shutdown of part of major hospital emergency services here in Melbourne, resulting in the furloughing of over 500 staff, the need for a new model of care, and ultimately exerting pressure on other health services as well. So there are an array of activities, including those described in this study, that can be implemented to strengthen internal protection, particularly education and communication activities as a component of in-service training to provide healthcare workers with confidence in their capacity to work safely in the continued response to COVID-19, but also in the event of a future pandemic. It's really important to implement these in preparation for future events, given health systems are a critical infrastructure and therefore require careful consideration and action before the pandemic event, ideally. So adopting these sorts of recommendations ahead of inevitable pandemics allow healthcare workers to develop the skills to implement the pandemic plan effectively, resulting in better health outcomes, social and economic outcomes as well, for healthcare workers and the community that they serve. So research findings from past pandemic experience like this should serve as the basis of frameworks and interventions that assist healthcare workers in responding to future pandemics, including the current pandemic. And policymakers and health service planners must be well supported to provide evidence-based direction and inform relevant policy initiatives and interventions to better support frontline healthcare workers. In terms of public health preparedness, comprehensive preparedness means continuous planning, consideration of implementation that is contingent on performance outcomes, and importantly, taking corrective action as required. So thank you very much for listening. I hope you found this helpful, and I hope you enjoyed my additional insights from a public health disaster management perspective. Bye for now.